Here are a few cases of an intraoperative zonular dialysis and the way in which it's managed. What? Sorry?
Audio is a little muffled.
Can you hear me?
We can hear you. It's a little muffled.
Shall I try? Can you hear me now?
Yeah, it's okay now.
Move
It's
the
okay
mic
now.
a little closer.
It's
Come a
bit
little
clear.
closer. Here are a few cases of intraoperative zonular dialysis and the way in which they were managed. Now, dealing with the preoperative zonular dialysis is a planned event where the surgeon has enough time to evaluate the extent of the zonular dialysis, either on a slit lamp or aided with a UBM, can have a strategy in place. Both the patient and the surgeon know what they are in for, and you're likely to know what the results could be like. Now, this differs from an intraoperative zonular dialysis, which is completely unplanned, catches the surgeon by surprise. He almost never can tell what is the extent of the zonular dialysis. Intraoperatively, a new strategy needs to be put into place, and for all the above reasons, you may sometimes have a compromised end result. Let's see a few such cases. Now, this patient with a pseudoexfoliation and phacodonosis is a good candidate for a capsule tension ring. After achieving a pupillary mydriasis and making the rhexis, the surgeon now introduces a suitably sized CTR with a hand-on maneuver in through the main incision into the capsular bag. The trailing eyelet is hooked on with a Sinskey hook, which is rotated into its position in the subcapsular base release, giving you a nice amount of zonular stability. In this case, while attempting to remove the last fragment of the nucleus, the surgeon notices a downward flap of the superior capsular bag, signifying a zonular dialysis. He attempts to put in some viscoelastic, which actually makes the zonular dialysis worse, and there is a vitreous disturbance. The surgeon now introduces a CTR, and as you can see, it progressively goes in, and there is a progressive opening out of the bag. The trailing eyelet is hooked onto a Sinskey hook, and it is rotated into its position and disengaged with a spatula from the opposite side. You can note that there is a peaking of the pupil, which signifies managed with the help of small Barner scissors, and at the end you have a nice round stable bag and a nice round pupil. Now, while attempting epinucleus removal in this particular case, the surgeon notices linear folds in the underlying capsular bag, for which he performs a viscofluid exchange. The CTR is then introduced again through the main incision in a hand-on-hand maneuver. This technique of introduction of the CTR is the linear circumferential delivery of the CTR in the capsular bag. The trailing eyelet once more is introduced into the eye. It is rotated. Its disengagement is such that both the open ends of the loop should be away from the subluxation. Here, by doing irrigation aspiration, the surgeon performs a viscofluid exchange, and then once more a CTR is introduced into the capsular bag. Please note that the introduction of the CTR always has to be from a point away from the zonular dialysis to then make the zonular dialysis worse. And at the end, you've got a nice stable bag. At the end of phacoemulsification, this surgeon is introducing a single piece lens but pushes down backwards on it, resulting in a rotation of the IOL, and it is brought into such a position that the haptic goes and sits against the weak area of the zonules, giving you a stable bag. This seems to be uneventful phacoemulsification. At the end of nuclear emulsification, the surgeon removes both the instruments from the eye, only to find that there is a zonular dialysis superiorly. The bag is insufflated viscoelastic, and the surgeon now again puts in a CTR. It's always important to note what is the angle of entry of the CTR. Something too shallow would it make it end up in the angle. Something too deep would make the CTR come back out upon itself. Now, in this case of grade 2 nuclear sclerosis, after a successful second chop, you can see a failure to disengage the probe resulted in a zonular dialysis. The CTR in this case is introduced with a fishtail technique, which is a safe, effective, easy to perform, zonular-friendly technique, which now no longer requires a circumferential delivery of the CTR, which has its own inherent issues. So how is this technique of a fishtail CTR? How is it done? A CTR is taken, it is bent, and the bent CTR is held with a pair of forceps. The apex is introduced to an unenlarged main incision and then under the lower rhexis edge. Then, turn by turn, each of the eyelids is engaged and slipped into the eye and introduced under the corresponding capsular bag. Without needing to do a linear circumferential delivery of the CTR, it becomes a fairly safe method of putting in a CTR. Now, the use of an injector to inject a CTR for an intraoperative zonular dialysis is great because it allows for ease of delivery because we're injecting exactly at the same plane of the capsular bag. Now, here's a patient with a grade 3 nuclear sclerosis, and after performing 2 chops, the surgeon notices that the bag is subluxated, which is not allowing the nucleus to turn. Attempts to put in a CTR, but halfway down the introduction of the CTR, or the attempt to do so, there is a resistance in the further introduction of the CTR. In fact, there seems to be a tipping backwards of the lens, which means it actually made the zonular dialysis worse. The bag is now supported with a capsular hook, giving it vertical stability, after which the surgeon completes the introduction of the CTR into the capsular bag. With ease and care, is now able to complete the nuclear emulsification, the irrigation aspiration, and the introduction of a single-piece lens. Yes, we did not have a 3-piece lens. I would have preferred to put in a 3-piece lens supporting the capsular bag at 2 o'clock. But once this was done, the end result is fairly satisfactory. So what really is my learning? When you're dealing with a patient with an intraoperative zonular dialysis, the mere adding of capsular hooks to support the capsular bag and no CTR is a little dangerous because we cannot always tell what is the extent of the zonular dialysis. So even if you do a very careful slow motion phaco and only have used hooks and the subluxation be large, as was in this case, the entire capsular bag is just absorbed at the end of the nuclear emulsification. So what would be a safer bet? Yes, you go ahead and use capsular hooks to support the capsular bag to give you a vertical stability. But in addition to that, prior to nuclear emulsification, it is important to introduce a CTR to give you a circumferential stretch of the capsular bag and no longer make it endangered for the probe to accidentally pull it out. With ease and care, then the surgeon can complete the rest of the nuclear emulsification. Now, this patient with a grade 2 nuclear sclerosis ended up with a zonular dialysis, for which you can see a CTR being introduced with a hand-on-hand maneuver. The point to be noted in this particular case is that ever after you've introduced a CTR, if you can see any of the edge of it, it actually signifies that you've got a subluxated bag and it's not adequate support. In this case, additional support was provided with the sclerofixated Emmett segment. Now, this Emmett segment or the tension segment can be introduced even into a phakic eye in order to stabilize a subluxated capsular bag. So what you can do is put in the capsular tension segment through the main incision, keep it at its proposed site of fixation. The eyelid is hooked on with the help of capsular hooks introduced via the limbus, and it is pulled out, which gives you a large quantum of vertical and circumferential stability, which allows for ease of emulsification. At the end of the surgery, after the IOL is in, you can sclerofixate these. And this is the last video. It's really hardly any time for this, that you can take 2 needles connected to a tenoproline suture. It is passed through the eyelid of a C into the capsular bag at the proposed site of fixation, and 2 needles, each of the 2 needles, turn by turn, is railroaded and exteriorized to come to lie at a point 1.8 millimeters behind the limbus in a grooved scleral tunnel. Once the 2 needles are exteriorized, so you have the needles which have gone through the eyelid and both exteriorized at the proposed point of fixation. Both the needles are cut and the suture ends, which are now long, are pulled out and they are tightened, and the extent of tightening is just adequate to give you a good centration of the IOL. With that, I come to the end of my presentation. Thanks, Sudeep, very, very much for me and part of your team.
Thank you, Suvira. Perfect timing and great presentation.